for that. And what's nice about this NovaProach implant is that I can really put it in from any angle. So I can put it in as a direct anterior with the patient in a supine position, but also I could use an oblique corridor. So I've got an oblique holder for it, and so I can really put it in from the lateral corridor, the anti-psoas corridor, or anteriorly. And in each of these instances, because of the way the screws are designed, I can almost always get 4 screws in. So often when I put it in an ALIF, I can kind of get screws, maybe 2, maybe 3. But my anterior column support with screws is much more reliable with this variability in our approach. So I was just to take a few minutes and show some cases with my experience. I think I've done a total now of about 40 cases, maybe 80 levels or so on average. Again, what's special about this implant is the ability for the implant to match multiple different trajectories. So whether you're coming from direct anterior or obliquely or laterally, we've got the ability to actually put the implant in using either a oblique insertion point or an anterior insertion point, and to put in our fixation screws reliably, and reliably get 4 points of fixation. The implant sizing is also interesting because I think so often when we think about how we ask for our implants in the operating room, we tend to say, well, 12 millimeters anterior height, 14 degrees. And to me, that never makes sense. Really, I want to focus on a posterior height. What I'm trying to do is get some posterior inner body height. I'm trying to really optimize the indirect decompression. So my rule is generally I like to have a minimum of 7 millimeters, more often 8 millimeters of posterior height. And I'll actually work my release of that inner body space until I'm able to get that posterior base distraction. Oftentimes actually taking down the PLL in my ALIFs. But I really like to get at least 7 millimeters of inner body height. So these implants, you can still ask for them by lordosis and anterior height, but you can actually ask for them by posterior height as well. And that's what I tend to do, is I tend to ask for the posterior height, and I work my way up from 4 to 5 to 6 to 7 of posterior height, then I build in the lordosis. I think that really optimizes my indirect decompression. And then again, our screw trajectories allow you to get 4 screws in just about any level of the spine. So this is my first case. This is probably over a year ago now. Is a patient who had a isthmic spondy that actually fused at L5S1, and that had been long-standing, and then subsequently had significant scoliosis as well as degenerative changes above. The stenosis is worse at L3-4 and L4-5, and had already had 2 prior decompressions at those levels. So in this case, I went ahead and went anteriorly, and I went from L2 to L5 anteriorly. The 5-1, you see very high pelvic incidence, high sacral slope, that was already fused. So I went from 2 to 5 using a paramedian approach. And using this cage, you can see here intraoperatively, we got the patient supine, paramedian approach. I was able to put it in the cage obliquely, and then posteriorly I decompress this and use pelvic fixation. And actually at L5S1, that level that had the olisthesis that was fused, I actually put a transosseous screw from S1 into L5 with pelvic fixation. And this is what that looked like 2 to 5 intraoperatively. You can see I was able to really get that cage, instead of scoliosis, I was able to really horizontalize those levels that were really quite oblique preoperatively, get some good posterior column height there. And then, I don't know if we got the post-op here, but on the post-op in the back, I put transosseous screws from S1 into L5, pelvic fixation. I think I went up to L2 in the back. Is that right? Yeah.
So you angled the screws up to go through the S1 formerly end plate into the body of L5.
Yeah, sort of a Bowman technique without the fibula.
Yeah.
But yeah, putting 2 screws from S1 into L5.
Worth noting that you only put the screws in one of the vertebral outs in the anterior part, which is something you commonly do.
Yeah, I'll point that out, is although I could routinely get 4 screws in this because there are so many screw holes, in deformity, oftentimes I'll just fix the cage to one end plate. because I do a lot of work by facetectomies in the back, so I get further sagittal plane correction as well as coronal plane correction with the facetectomy. So in most of my cases, you'll see I'll have only 2 screws. Typically, I'll put screws going down in the sacrum, then up into the other levels. And that basically allows me to have some more correction from the back. Here's another case that I thought was an interesting one to show because of the advanced calcification of the vessels. So when you look pre-operatively, you can literally sort of see an angiogram. You can see the calcification of the aorta, the common aortic vein. And this is the case where I think a lot of people might say, I'd rather not do an anterior on this. The fragility, the potential of fracturing that atherosclerotic plaque is significant. So we want to minimize our retraction of vessels. And you see how the aorta comes right over the 4-5 level, and that bifurcation in this case is really relatively low. So minimizing retraction of vessels is a big part of, I think, safety in spine surgery, especially in some of these older patients. So in this case, I just did a L4 to S1 as a patient who had, again, a post-laminectomy deformity with persistence of radicular pain, a lot of collapse at 4-5, foraminal narrowing at 4-5 and 5-1. So again, using a slightly more oblique approach, I was able to minimize my retraction at 4-5 with those atherosclerotic vessels and come in an anti-psoas approach with the patient supine. You see how nicely we were able to really open up that posterior height at 4-5 and 5-1. So restoring that posterior height. In general, I get at least a 7 or an 8 millimeters of posterior height to get that indirect reduction of the foramen. And again, at 5-1, I put my screws down into the sacrum, 4-5 up into L4, and then I'm able to get some rotational correction with the facetectomies in the back by not locking those cages in. It was very easy without retracting the vessels for you to get these cages right onto the midline. And again, that's, I think, testimony to the fact that these cages can be inserted at 5-1. I'm usually inserting the cage. Whereas a direct anterior, and at 4-5, that oblique insertion can be really quite useful. And again, this is done with really relatively minimal retraction of the vessels. To show you another example that's a common scenario in my practice is the patient who's had prior ventral hernia surgery. So between abdominoplasties or prior ventral hernia surgery, patient with mesh, my preferred approach in my ALIF is to go medial to the rectus muscle. Again, generally you get to at least L3, most of the time to L2, pretty easily through a paramedian. But in patients who had prior abdominal surgery for either abdominoplasty or mesh or ventral hernia, oftentimes I'm working in a more lateral window. So I work in a window lateral to the rectus, so between my oblique muscles and my rectus muscle. And this is the case, patient with a pretty significant scoliosis here. Interestingly, he was a 74-year-old with some comorbidities, and most of his trouble was really, in this case, right-sided radicular pain. She had right L4 and L5 pain, had a prior decompression at those levels, and the actual scoliosis wasn't terribly bothersome to him, but severe foraminal narrowing at 4-5 and 5-1. So again, in the operating room, this is my standard paramedian approach, but in this case, going lateral to the rectus. And I was able to really correct, you see the obliquity here between the L4 and S1 there, that severe obliquity, and that foramen at 4-5 is so narrow. So I was able to really get this cage from a left-sided approach over onto that right side and really get a better horizontalization of 4-on-5 and 5-on-1. So sort of intentionally putting these cages a little bit offset. And again, as you see, the dramatic improvement of the foraminal height. So really by getting up into that concave side, open up the foramen, indirect reduction. Now, in my hands, if I were going to percutaneously fix this in the back, I would have, again, put in 4 screws. I put in screws above and below. But in this case, in the back, I still did wide facetectomies to get more correction. I don't think we've got the post-up on there. But the reason I put screws in on one side is to, again, allow myself the ability to get more correction from the back. But if you prefer to perk these from the back because you've got such good indirect decompression of the framing, then I would probably have put 4 screws in. And again, this cage really facilitates 4 screws going in. So that's a brief overview of some of my experience with this Nova approach, this so-called one-lift cage. And if anybody wants to see more closely, maybe Michael, do you want to walk through on the demo here and show
show the
the anisoas in the lateral approach?
Well, sure. I think that
Let's do it.